Okay. So I would like to welcome everybody to our internal medicine ultrasound rounds. This is the first one for this academic year, so thank you all for joining. This is recorded, as I had mentioned, so you can always find this on our website, imsono.ca. I just want to thank everyone for joining us once again. It's a more intimate setting here, but this hopefully will allow us to have good discussion around this case that Alvi and Kirk will be presenting. And so feel free to, if there's any burning questions or burning discussion points you want to talk about during the talk, just feel free to put it in the chat. I'll be monitoring it and either replying to it or we can address it at the end of the talk as well. So I would like to introduce Alvi and Kirk, who are PGY2s in our internal medicine program. They are now completing their 1-month rotation with us on the internal medicine ultrasound service. They came in with a lot of enthusiasm and interest in ultrasound, having done a lot of self-education in ultrasound, doing a lot of reading. So when they came on, we started the rotation running with some really high quality scans and even got into some advanced topics throughout the rotation. It was really a pleasure having them, and so they're going to round out their rotation with this case. Take it away, Alvi and Kirk.
Yeah, thank you so much, Dr. Yu. It's really been a great pleasure working with both yourself and Dr. Satin. Certainly, we recommend it to all the other junior viewers who are here to consider a POCUS rotation. So I guess we'll just go off and start on the case. So we'll be presenting a very interesting clinical case about RV failure, and we kind of titled this case presentation affectionately "Show Some Love to the RV," because we often find that people, the healthcare practitioners, are often very focused on LV function, LV systolic function, and RV failure is often kind of overlooked. And so we're hoping that in this case presentation, we can talk about some interesting POCUS findings as it relates to RV failure, and talk about a case in terms of management, and also discuss some of the hemodynamic consequences of RV failure. Trying to hit next here.
Oh,
looks like we got some technical difficulties.
Starting off with some technical difficulties here. Sorry, guys.
Here we go. Can everyone see the transitions, by the way, that we're going through right now?
Looks good, guys.
Awesome. Looks beautiful.
Perfect, perfect. Okay, so I'll just start off with just a brief introduction about the clinical case that we had the privilege of seeing. And this was a patient that was admitted to one of the medicine teams here at University Hospital. She was a 91-year-old female from long-term care who initially presented with falls in the setting of this 1-month history of functional decline. And these are things that we kind of gathered from the admission note as well as talking to the team. In terms of salient items for her past medical history consisted of coronary artery disease. She had a remote end STEMI ×2 in the past. There was a question of congestive heart failure, but we weren't able to locate any recent echo for her at the time of her admission, of course. There was also a question of atrial fibrillation, and she has a diagnosis of psoriasis as well. And these were some of her medications. As one can imagine, of course, the medications seem to fit in line with her previous known diagnosis. She was on Lasix-40 BID, candesartan, spironolactone, metoprolol for her AFib, presumably, Plaquenil, as well as nitroglycerin spray. These were some of the vitals that she initially presented with. So as one can kind of take a look just in terms of highlight overviews, she was a bit tachypnic and her blood pressure was sitting on the softer end, but more or less hemodynamically and vitally was stable, at least in presentation, and was satting well on room air. The individual who did the physical exam initially when she had come in, her JVP was quite unremarkable. She did have some mild edema initially, but cardiovascular and respiratory wise, relatively unremarkable. And within the coming days, within the coming days, they identified that these were initially the active issues. So kind of in an internal medicine framework, the first issue that was identified was fall/syncope. And the differential diagnosis certainly was, is there an element of hypotension or orthostatic hypotension that was leading her to having these falls? As we had mentioned, her initial BP was quite soft. She was hyponatremic with a sodium of 128. And given her relevant cardiac history, The team had also decided at this time to order an echo to look to see if there's any structural abnormalities that may be leading her to having these fall and syncopal episodes. They had also identified an AKI. Her creatinine was 180 initially, up from her baseline in the 90s. And certainly given her kind of clinical picture of functional decline and her relatively looking dry on exam, they were entertaining the idea, could this be pre-renal versus cardiorenal, of course, given her cardiac history. Her urine cultures also came back positive for E. coli. From what we understood is she was not the most reliable historian, but given the fact that her lactate was initially kind of trending up towards 3, they had done a CT scan within the first few days, which did show some radiographic signs of emphysematous cystitis. And so the question of sepsis came about as well. Is she kind of in a urosepsis picture? And understandably, the plan that they initiated was to hold her diuretics. So her Lasix and spironolactone were held, and she got a generous amount of fluids, about 4 liters over the first 48 hours. And as expected as well, they started her on broad spectrum antibiotics. And what they kind of noticed initially, of course, from a biochemical, at least perspective, there was an initial improvement in her creatinine. It did start to trend down. Her sodium started to come up. But one of the things that they had noticed is that she was still persistently hypotensive despite the aggressive IV fluids. And over the next 4 to 5 days, despite the administration of IV fluids as well as antibiotics, they started to notice that creatinine had started to slowly climb up above 200. And these were levels, we should point out, were worse than when she initially presented, despite the fact that, although her urine output was still on the lower end, they ruled out post-renal etiology as well as renal etiologies. Her creatinine started to climb up, and she started to become increasingly hypotensive, with her systolic often dipping down below 80. And what's interesting to mention is that her lactate also started to climb up. And take into consideration all of these factors, at this point, the medicine team was rightfully concerned about maybe a cardiorenal picture for her AKI, as well as impending cardiogenic shock. At this point, they had resumed her oral Lasix as a measure to reduce some of the volume to see which way things would head. And it was at this point as well that they consulted our team to assess with our point of care ultrasound to take a look at the volume status. And one of the reasons this was helpful is that it would help guide further diuresis management. Were they diuresing this patient too much or too little? And more importantly, can the patient actually tolerate further diuresis? And we took a look both thoracically as well as the cardiac focused to do a further hemodynamic evaluation.
Yeah, so I'll just briefly introduce myself. I'm Kirk, and I'll be going through our initial assessment here with our focus ultrasound there. So that's just a little kind of in the top right screen there, you'll see like a 3D representation of how the orientation is in space, and hopefully that'll give you some idea of how we obtained these images here. So our first image here is representative of a parasternal long axis view, okay, with the right ventricle being at the top there, the aorta, and then the left atrium down here. We were fairly new in our POCUS blog, and so these images aren't necessarily super ideal, but between the two, we hope we can kind of describe what we saw there. So this would be the left ventricular outflow tract, although ideally it would have more of the left ventricle there. So from this image, we see a little bit of this rule of thirds going on, which is when we look at the RV outflow tract, the aorta, and the left atrium. And the left atrium does look a little bit larger, but nothing crazy there. And then hopefully on the right side here, you can appreciate that there might be some minimal contraction going on that bottom wall of the left ventricle, kind of in keeping with what we suspected or increased our suspicion for left ventricle reduced ejection fraction, and notably some MR there, which we wouldn't necessarily grade as super severe in this case. So this just kind of increased our suspicion for a few things, but we wanted to get more views of the heart there. So we went naturally to our next standard view, which is our parasternal short axis here. So we're looking at the ventricles in cross section here, with the left ventricle being on the bottom here and the right ventricle being on the top. Just offhand, noticing you can see you're in the left ventricle at the mid papillary level with our papillary muscles kind of coming in on either side here, and then the right ventricle being on top. Just off like first glance here, you can identify that the right ventricle does look quite a bit larger than you would expect with a parasternal short axis. Again, we can appreciate that there's poor kind of muscle contraction and thickening of the muscle of the left ventricle all the way around. But really interestingly is if we take a look towards the septum here, you can see it's not thickening in terms of the muscle, and also it appears to be flattening. There seems to be flattening in both these like systole as well as diastole, probably more so in diastole here. And so we get this classic D-shaped ventricle of the left ventricle there. So our findings were this large RV, the septal flattening throughout the cardiac cycle, but mostly in diastole there. And so this can be an indication of kind of right ventricle volume and pressure overload. When it happens during diastole, we think more so volume overload, as all that blood returns to the right ventricle, whereas in systole, you'd expect like the contraction to be pushing, and so that the right ventricle is producing more pressure. And so there's a little D-shaped ventricle there, and I hope we can kind of convince you that that's the case. We do have some further pictures later on post-diuresis, which we'll kind of compare and contrast, and hopefully you'll see the difference there. And so one of the things is we always look for quantitative values of what we're seeing. And so with kind of the understanding that like this is going to be a really user dependent, and what we get on POCUS can vary from one person to the other. Often issues can be with foreshortening of the ventricles there. So if you don't get the papillaries in view and it's in perfect cross section, you can actually maybe sometimes make it look like there's a flattened ventricle. So ideally having an expert in POCUS who is doing this day in and day out and can kind of make sure that you're in that mid-ventricle perfect cross-section is ideal. And so one of the indicators for this, and if you want to put a number to it, as opposed to just a qualitative value, is this eccentricity index. And so you take kind of the line that's parallel to the septum, and you put that over the perpendicular line there, and that gives you a bit of a ratio. And this image from POCUS 101 can help us kind of see. So if it's less than 1 or 1, you're expecting it to be a fairly kind of concentric contraction there. Whereas if you see a value eccentricity index of greater than 1, it raises your suspicion for a right-sided volume overload there. And so we were able to do that, and here are some still images of the cross section of the heart there in the parasternal short axis. And so during systole, we have a value of pretty close to 1, measuring here, getting that parallel line and putting it over that perpendicular line. And then once again in diastole, we have a little bit more there. So you can see that the D1 is quite a bit smaller than D2. And so that gave us a larger eccentricity index. So further kind of raising our suspicion for this volume overload that we were seeing. Other things that we were able to do on our first assessment was to get a apical 4-chamber view and assess for mitral valve and tricuspid valve competency. And so we can see quite a bit of tricuspid regurgitation here. It seems to be going almost to the back wall there, filling about maybe 30 to 40% of the left atrium. And the actual root of this stream is fairly thick. And we can also see that with the mitral valve as well. So quite a bit of a thick base there, and quite a substantial, significant, severe mitral regurgitation there. And so some other findings that we were able to do to assess for heart function here is we got a LVOT VTI, which is an indicator of stroke volume. When you kind of compare that to the aortic outflow tract, the the left ventricular outflow tract diameter, you can get a idea of stroke volume here, and you're generally looking for a VTI of around 18 to 20. That would be normal. So this is kind of consistent with that decreased contraction we were seeing in that left ventricle, and probably a reduced stroke volume, which could be contributing to a bit of a cardiogenic picture of shock, as well as the sepsis that they were currently treating. And then additionally, we got a what we would call a tricuspid regurgitation waveform here with our continuous wave Doppler, measuring that gradient. So generally you're looking for a gradient of like 40 would be fairly significant when you add on kind of IVC measures that we did measure. But even just with the regurgitation itself, the pressure was estimated to be around 40, which would be fairly significant for her.
I will also say that, like, in the setting of severe TR, our measurements for like the Doppler, continuous wave Doppler, are often underestimated. So the true value of RVSP may actually be indeed higher.
And IVC remains kind of a contentious topic with volume overload. And so we were kind of cautious in measuring this, but you can clearly see that the IVC is plethoric, and we measured it at greater than 2.1 centimeters here, with very little collapsibility, kind of further consolidating that opinion that there was a bit of volume overload when taken in context of all the other findings that we had found. And then so this nice little graph or table here helps us represent how much pressure there is. So we had an abnormal size with abnormal collapse, and so it was estimated about 15 millimeters of mercury for the right atrial pressure there. Another unique finding that we appreciated here was a intraatrial septal bowing. Now, this is a subcostal view of the heart, the right atrium kind of in the near field and the left atrium in the far field there. And if you appreciate the septum here, seems to be bowing into the left atrium. And that's indicator that the right atrial pressure is higher than the left atrial pressure. Her left atrial pressure was probably fairly high, although we didn't calculate it. She did have quite a bit of significant mitral regurgitation, so it would be likely higher than the standard pressure for that part chamber of the heart. So we can say that roughly we'd expect that the right atrium to be greater than 15 millimeters of mercury, which would be the standard pressure, although we can probably guess it would be a little bit higher there. So a very interesting finding. And I'll hand this one off to Alvi there.
Yeah, so taken together from all of our POCUS findings, we were able to surmise essentially that, we had a lady here who certainly indeed had like a very severe biventricular failure. We were able to appreciate she had moderate to severe MR and TR, as well as both left and right ventricle were quite dilated. And interestingly, with the D-shaped septum, we were able to also make an inference that certainly there was an RV volume and pressure overload hemodynamic effect that we were witnessing. And with the D-shaped septum becoming more prominent during end diastole, we can infer that this volume overload issue was more of a predominant problem. Again, with the large non-collapsing IVC, take together with the interatrial septum bowing, we can surmise that certainly there was a high degree of right atrial pressure as well. And all of this in conjunction with the biochemical parameters that we were seeing, so her rising lactate, elevating creatinine, and her progressive hypotension, allowed us to really query, is this patient in cardiogenic shock? Now, I will say that, of course, her LV function was quite low as well, so there may be an element of reduced LV function that was leading to cardiogenic shock, but we'll also entertain this other idea. So before I go there, we would like to also mention, of course, around the same time, the team had done the TTE, like the comprehensive echo, and a lot of the findings that we had initially seen on the POCUS were corroborated by the TTE here. And this is the slide that we are hoping to kind of have a discussion about. So we borrowed this image actually from the European Society of Cardiology, and this was actually in their like acute PE management talk. And you'll see various images that show more or less the same thing about how RV failure independently can lead to cardiogenic shock. There's a lot of like mechanistic and physiological parameters that kind of lead to how increased RV afterload can cause a decline in obstructive shock in the setting of PE. But if we kind of focus on and kind of think back to what we were looking at with the parasternal short axis, about the D-shaped septum, there's certainly an element of an enlarged RV with decreased contractility that would certainly have a mechanical effect on reducing LV preload and thereby reducing cardiac output, causing low systemic blood pressure, and then ultimately leading to cardiogenic shock. And so that was what like we suspected was a purported mechanism as to what might have been leading to hemodynamic shock, cardiogenic shock in this patient that we were seeing. So the suggestion we had made in conjunction with discussion to the team was that, certainly this patient was put back on oral Lasix at her home dose, but, we made the suggestion that, one could argue that actually she would require even further diuresis. And it's a tricky thing, especially since, on a clinical exam, as we kind of already alluded to, the patient actually looked quite, quote unquote, dry. She didn't really have, her legs actually, when we did our initial assessment, were quite, bony thin, and she didn't have like a very easily identifiable JVP. And so we can, one can kind of imagine that in these certain circumstances, depending on the practitioner, sometimes management can go in either direction. And one may be more willing to give fluids. But our recommendation was, let's try some aggressive diuresis. So within the first day, she received 40 milligrams of IV times 3, a total of 120 milligrams. And she responded quite well, approximately 2 liters of urine output. Her blood pressure did improve to the systolic at 90 to 95 and diastolic 55 to 65, and her lactate resolved as well. And we also did notice that there was a slight reduction in the creatinine. We made these recommendations that around this time, the cardiology team was actually also involved. And given her severe biventricular failure, one of the kind of asterisks to our kind of suggestion with giving Lasix was that certainly if we did see it like a decline in her blood pressure, that adjunctive measures with supplemental inotropes and vasopressors would be required. Ultimately, I think the team in conjunction with cardiology deemed that it was not necessary and also not probably within the patient's goals of care. But within the first day, we did see some benefit. We'll also mention, of course, that eventually the MRP switched to Lasix infusion, which they held for a few days. And we went back a couple of days later after that significant phase of diuresis to reassess the heart to see were there any structural changes and POCUS findings that would prove that hemodynamically things were heading in the right direction. And sure enough, I think we can all appreciate that this, on the left-hand side, we see the initial assessment. As everyone can imagine, that D shape that comes into view at the end diastole looks less like a D and more like an O, which is kind of more in keeping what you would normally see in normal kind of cardiovascular physiology. Albeit one can still imagine that the RV is still quite large. So certainly, we didn't cure the patient overnight, but certainly from a structural standpoint, there was some resolution. And we just put those D and O just so that viewers can kind of imagine that the shape is actually changing. These are also very subtle things to look for, but of course, I hope the viewers can kind of imagine that. And again, taking a look at the IVC, on day 1, when we had examined, it was large and non-collapsible, wherein after the couple of days of diuresis, the IVC diameter went down below 2.1 centimeters, and it was collapsing, but not greater than 50%. So her, certainly she still probably had elevated right atrial pressures. And lastly, that unique finding of the intra-atrial bowing that we were seeing from the right atria to the left was not apparent on second assessment, which again would probably lead us to believe that, a certain degree of diuresis has helped to reduce the pressures on the right side.
Yeah, so we want to thank you guys for listening to our talk. But the main points that we want you to kind of take away from a case like this is that this is actually quite more common than we would predict. This is, Dr. Yu mentioned to us, like he sees this quite frequently, and can be something that's overlooked, and we do appreciate that. And I think it really illustrates the importance of POCUS, especially for these patients. Her initial picture did look, you could argue, very much volume down with that hypotension, the AKI, the hyponatremia. But in fact, it may have been kind of led to by the right ventricle contribution as well. So definitely takeaway points would be the right ventricular failure and the progression to cardiogenic shock, where that right ventricle with the pressure and volume overload is impacting that filling of the left ventricle, reducing the stroke volume, and therefore kind of contributing to decreased perfusion. And then also, not all patients are equal in terms of a clinical exam. Like our patient here, she appeared quite dry on clinical exam with those woody legs, minimal pitting edema, hard to appreciate JVP, and so POCUS can help supplement that physical examination. And so additionally, the benefits of POCUS being that reassessment period, that quick assessment at bedside, and being able to visualize that change and see that you're on the right track can really allow for quick management changes and help patients really improve and get better. Unfortunately, our patient here with her multiple comorbidities ended up going palliative further along in her course there. But I think it's a terrific learning point for everyone to kind of appreciate here. And if you're ever stuck in that situation where you're trying diuresis and things aren't getting better and the picture's not looking like what you'd expect, is to start from scratch and reevaluate, and definitely consider POCUS as one of those tools that you can use. And with that, we really want to thank Dr. Yu and Dr. Satin for the terrific feedback, the bedside help, and kind of real-time feedback. I think I've walked away from this course with, or this block with like a newfound appreciation and a new tool that's definitely going to supplement and help me on my way to becoming a good SMR. And I feel Alvi appreciates the same way, and we thank you all for listening to it, and hopefully this case can provide you with a little bit of kind of appreciation for rarer things and to reevaluate. And so with that, we'll kind of open the floor up to some discussion. Thank you.
It's amazing, Alvi and Kirk. Thank you for the wonderful presentation. And so I'd just like to open up the audience if there are any questions or concerns or discussion points.
Hey guys, great talk. Really appreciated the animations. We had a similar case on our ward here in the whole team. It was like very similar to what you had. It's a lady who came in with cellulitis. She had known kind of pre and post capillary pulmonary hypertension, and we had kind of already started her home antibiotic or Lasix at the time, but we got called to her one morning for like hypoxia. She looked blue in the lips. She had a lactate of 6. And so we focused her at the bedside and, saw pretty much what you guys did with, really bad systolic septal flattening. And she was hypotensive. And so we called the ICU fellow, who was fortunately very fluent in ultrasound. And we were able to have this, physiology-based discussion around the patient's status. And they ended up taking her down and putting in the Swan-Ganz and starting milrinone, sildenafil. And I feel like in an alternate universe where we didn't have POCUS, if we see someone hypotensive with a lactate, she would have gotten bolus to the walls and, would have had a very different outcome. So, I think this is like you guys said, it's a very difficult assessment, the RV overload on the ward. So, I think it's a very, I think, necessary skill for a lot of us as we enter SMR role.
Absolutely, Derek. I agree with you. Like, I'll admit I've been victim to that. You hear about a hypotensive patient and your first instinct is to trial a bolus of fluids, and that can actually have made a situation like this worse. So hopefully people appreciate that moving forward.
I think if you guys go back to your beginning slides of the case presentation, it's a very compelling story of somebody who may have sepsis or at least some kind of volume contraction, especially with the CT finding of emphysematous cystitis. So I think that story being compelling. I don't want to fault the team whatsoever for the initial bolus of fluids, and perhaps that was indeed the case at the very beginning of the hospital course. But I think it's important to point out that it really shouldn't just end there with our best guess of what the cause for shock is. surviving sepsis guidelines tell us to give 30 milliliters per kilograms of fluids in the initial couple of hours of somebody whom you're suspecting sepsis. And again, I think it was good that they suspected sepsis and tried to treat accordingly. But really, we can probably do better with our POCUS abilities. We should be able to do better than that. Concurrently throwing in some ultrasound, getting a sense of that cardiac hemodynamics to know what's going on before proceeding with our 30 mil per kilogram recommendation. That's that was an awesome point.
Mm-hmm. Yeah, absolutely.
Oh, go ahead. Sorry.
Oh yeah, I was just adding on that. Like I could definitely be convinced the same. Like just with that clinical picture, it all seemed to make sense, right? And the fluids would be, that's what the guidelines say, and so we tend to go for guidelines. But yeah, I agree with you. I think we can do better. I think POCUS gives us that tool.
Dr. Kale also made a great point here in the comments, saying that you guys did a great job talking about RV pathophysiology, because it's really one of the most difficult things to deal with. And so just wanted to maybe have you guys pull back to your sort of death spiral diagram, if you still have that there.
Sure thing. Yeah, just 1 second here.
Yeah.
Just a second here. Let's we're just gonna pop back a few here. Yeah, let's just end the show. The spiral, yeah.
Spiral of death.
Yeah, so you guys were reiterating sort of the end stage of the spiral, where we are getting into cardiac shock and essentially patient death. My actually emphasis is usually on the beginning of the spiral. That is really where our major interventions can help, especially if they're on the ward and not in the ICU. So I would like to point out that with any sort of increased RV afterload, whether it's from a PE or other types of RV overload, the RV starts to dilate as a response of it. And that initial dilation is probably the worst thing, most maladaptive thing that the heart can do, because it worsens that tricuspid regurgitation. As the RV dilates, that tricuspid annulus starts to increase as well. And so the tricuspid valve regurgitation worsens. And as that TR worsens, the RV volume overload worsens significantly with each cardiac cycle, essentially. And so if we're able to catch that at the very beginning, the diuresis that we can do on the floor can really save that RV potentially from that progression to the death spiral. Because once we get into RV ischemia, obviously systemic shock, we're in terrible, awful end stages of the disease process. So I think in this case, she was almost getting there. She was almost getting to cardiac shock, if not already, with the rising lactate and the blood pressure of 80s. But I think we were able to catch it early enough when we saw the RV dilation from both maybe pressure and volume overload, with volume overload being quite significant, and diuresing and trying to shrink that RV to both get the RV back on a better portion of the Frank-Starling curve, and also to reduce that tricuspid regurgitation and that vicious cycle of worsening volume. It really was quite key. And I think for the patient, there was certainly some room to go, but that initial diuresis I felt was quite helpful for her.
Agreed.
Are there any other questions or comments from the audience?
Sorry, I was a bit late, guys. I was just finishing up clinic, but I just wanted to say great job. I really like the pre and post diuresis clips. Reassessment and monitoring, what we're doing from a management perspective. The fact that we can do these on a day-to-day basis, I think, is one of the powerful parts of ultrasound at the bedside. Is that you don't have to order a test, wait a couple days, get it. You're just right there assessing the patient, and you gave a really great example of that.
Yeah, thank you so much for the feedback, Dr. Satin and Dr. Yu.
Okay, so if there are no further questions, I'll end the recording, and thank you once again, Alvi and Kirk, for a wonderful presentation.
Our pleasure. Thank you again.
Thank you.